So this is a 61-year-old woman who presented with the axillary mass, and there's no other systemic symptom or lymphadenopathy by imaging study, and no significant past medical history. So here is the excisional biopsy of the 4 centimeter mass, and that is performed. If the lymph node tissue is here, as we can see right here, and so histologically, what we can see here is that this is not a normal lymph node because it has an effacement of the lymph node nodal architecture, and we can see here the nodal and also in the background diffuse proliferation of cells that are composed of, if we go higher power, we can see that these lymphoid proliferations are predominantly small, and they are composed of these cleaved centrocyte, and so also we have intermingled large central blasts. So these are the central blasts, and the one that are smaller, the cleaved cells, and they are centrocyte. So in the background, what we also notice is these kind of sclerotic band, and they are surrounding these nodular area over here. So we can see this predominantly small lymphoid cell that are mixture of centrocyte and centroblasts, and if we also take a look at these nodular area, we can also appreciate this similar mixture of centrocyte with centroblasts, and the flow also show a clonal kappa light chain restricted population, that is B cell with co-expression of CD10 and lacking CD5. And again, if we look at this area, we have these nodular proliferation, and they're not the normal germinal center. We have these sclerotic band in the background, and we have these small to intermediate size lymphoid cell with pale open chromatin, and they are central blasts. And we also have a normal mixture of small lymphocyte. Here you can appreciate more sclerotic band, and based on the flow cytometry and this H&E morphology, and we need one more additional modality, which is immunostain. So immunostain, although the pictures are not available, which show co-expression of so we have immunostain that reveal these nodular area. They are positive for CD20, so that confirms that it's a B cell origin, and they have co-expression of CD10 and BCL2 in these nodular area. So it's the top differential is follicular lymphoma, and CD21 also highlight these area and these nodular area with the follicular dendritic cell meshwork, and these non-nodular area, which is the interfollicular area, they represent approximately about 40% of the entire excisional biopsy, and they lack any CD21 staining, so there's no follicular dendritic cell meshwork in this interfollicular area. And those B cells that are seen in this area, they express CD10 and BCL2. So with this flow cytometry showing these clonal kappa restriction, and this H&E showing these nodular and diffuse proliferation composed of small centrocyte and centroblast mix, and immunostain showing BCL2 and CD10 co-expression with the CD20 in all these B cells. So this is that diagnosis is classic follicular lymphoma, and we have these follicular and diffuse pattern. So follicular lymphoma is a very common lymphoma in the Western Hemisphere. It comprises approximately 20% of all lymphoma. So the current WHO identify a few variants of follicular lymphoma, and it also distinguish certain pattern of the disease. And so a distinct type of follicular lymphoma is seen in pediatric type is designated as pediatric follicular lymphoma. Pediatric type follicular lymphoma. It's an uncommon nodal follicular lymphoma that is seen mostly in the head and neck and present in the stage 1. So the one that we see here is classic follicular lymphoma.